over the internet, free for the world to watch. Our patient is here with 2 bad discs in her lower back. She's had back surgery before, not by me. She's from Canada. The surgery was done perhaps in Canada. Where was your surgery done? Was it Canada? It was done in Canada. So she's got this humongous incision. It's literally like 6 or 8 inches long on her back. And that was a long time ago. And you can see on her x-ray, we'll see in a moment, she's had a laminectomy on one side. And now she's having horrible back pain in her lower back. She's got one disc that's pretty collapsed. And then the other disc, L4-5, is got a herniation. And I believe it's the L4-5, L5-S1 discs that are causing her back pain. Based on her exam, I could see that's where the pain is emanating from. So we're going to fix L4-5 and L5-S1. And L4-5 is an almost normal looking disc. L5-S1 on the other hand is very collapsed. And it doesn't matter that it's collapsed because we can still get rid of the pain that's there. I'm going to go ahead and give you a little bit of injection, okay? Don't get upset. It's normal to feel a little burning. I apologize. So the other thing that she has a very interesting history. She's had urinary issues for years, many, many years, and nobody's ever diagnosed it. It turns out she has a herniation in her thoracic spine that went undiagnosed until she came here to Deuk Spine Institute. And you can see that the herniation is large enough, it's pushing on her nerves and her spinal cord. And apparently when she brought it to the attention of doctors in Canada, they just ignored it. That was after we had talked about it and I showed it to her on her MRI. But she's been having problems for years, urinary problems, for years. Now, it doesn't mean everybody with urinary problems has a problem in their spine, okay? It's actually not that common. But this was obvious and it was just missed by her doctors. Can it be missed in the States? Absolutely. Doctors in the United States do the same thing. It's just that you really need to go somewhere where they're paying attention to all the little details. All right, so we're going to start by fixing the 2 lumbar discs, and then we're going to move to the thoracic disc. And the thoracic disc is at T11-12. Now, if you feel pain, remember our agreement. You don't move, you just say ouch, okay? All right, I'm giving you numbing medicine, so it should help. But if you feel discomfort, let me know. Shot. All right, so we may need to go a little lower. We'll see. Well, we're starting out by accessing the L4-5 and L5-S1 through an approach in the back. There's some unusual bone formation at L5. That may actually not allow us into that disc space. We'll see. All right, good. 5-1 looks pretty good. 4-5 looks perfect in terms of the angle. I need to get 5-1 cleaned up. Let's do a little wagging. I think you need to wag just a little bit. I would say maybe the other way. Try the other way. So the first thing we need to do is we need to get the x-ray lined up properly. I think that's better. You see the iliac crest going through the L4-5 disc space. It's kind of offset just a little bit. Let's see if we can clean that up just a little bit. See that? I think it's about a degree more of wag. I'm not sure which way. Maybe half a degree to a degree. I think that made it worse. The other way. Let's try a little more. I feel like we're still not quite right. That's, I think, better. Let's just leave it there. I think that's good. We need to move the fluoro north a smidgen, like about half an inch maybe, and open up the plate in the back. Just a little bit. A collimator. All right. So before you really get going on getting access to the disc you want to fix, you really need to make sure the X-ray is showing you a true lateral, because if you don't have a true lateral, you could be basically going somewhere you don't want to go and not hit your target. So you have to use the X-ray to guide yourself. Yeah, thanks. I heard it. Yeah, just don't move, okay? It's important you don't move. You're doing great. Everything's fine. Shot? Uh-huh. Yep, no problem. You are going to have a little discomfort. There's no, don't put your hand here. There's no way to avoid that, okay? So don't be surprised if you have some pain. Some of it I can help you with, Shot. Some of it I cannot. What's that? Yeah, well, Shot. All right, so we need to get further south. Shot. Uh-huh. You're fine. Everything's okay. Shot. What do we do there? I don't know if she moved a little bit. I think we're just slightly off. I don't know if it's the orbit. Go ahead. I'm not 100% sure. I don't think that's bad. Let's just leave it there for now. Shot. 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 You held on it too long. Shot. 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 Can you help me out a little bit here? Huh? Yeah, just relax. Everything's going well, Sean. 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 Let's go AP. So far we've had just a drop or two of blood. She's doing very well. She's just a little unhappy with being poked at the moment, but that's part of the procedure. But go back to a lateral. You can see the laminectomy there on my side, the right side. Let me know when you're ready. Shot. Shot. You awake? Where do you feel that? Back. Okay, good. Where do you feel that? All right. Still in the back, right? Not down the leg? Perfect. You're doing great. I know this is a bit uncomfortable, but you're going to do fine. Remember why you're here, right? Shot. AP. Nothing down your leg, correct? So that's why the patient's awake during this part is I need her help to make sure that I'm navigating to the right part of the disc. Yeah. All right. Let's go to 4-5. No. I need 4-5 shot. And line that up properly. It's not terrible. It's very close. I'm not sure what you did. That's fine. Go ahead and go south. All right. Looking good. We're limited by anatomy. Hang in there, okay? I know this is a bit uncomfortable, but I promise you everything's going fine. Nothing bad's happening. Shot. 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 It's lining up very nicely. Just about there at this disc. Shot. Huh? What is it? Shot. She said what? Shot. What did she say? Yeah, that's fine. Shot. I understand. It's going to be in your back. That's what we expect. We just don't want it to go down your leg. Shot. Promise you, I'm almost done torturing you here. Shot. So close. Yeah. Are you comfortable? As comfortable as you could be, right? Shot. I think I want to be a little bit lower. We're very close to where we need to be at this point. Shot. And she's doing so well. Shot. You can see the iliac crest passing through L4-5. Shot. We're right at the facet joint. Shot. You're doing really good. Promise. Shot. 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 Give me an AP view. So we're going to switch our view from a side view to a front back view. Then 90 degrees. You're doing great. Just hang in there. Looking really good. Back to a lateral. See all the bony growth just below the needle. It's coming off to my side at 5-1, the disc below. All right, very close. Anything? Yeah. All right, just settle down. It's okay. No, we're going to come up here. Yeah. We're going to go up to Yep. It's exactly. She's fine. Yeah, just a 1.5 feet away. Yeah, you're fine. All right. So it's 11:12. Everyone's in agreement? There's a large herniation at 11:12. And it's pushing on the nerves and it's basically the bottom of the spinal cord. It's left side, we're all in agreement? So I'm going to need, just settle down, you're doing great. So let's go ahead. 11:12, we're basically going to be the bottom 2 ribs. We know the needle's at 4-5. So let's go ahead and do an AP view, please. So I could use a couple of things. Number one, I could use obviously the ribs to navigate shot, but I could also use and there's your bottom rib there, T12, but I could also see the needle. Let's go south just a little bit and just show us the needle shot. I think we need to go a little bit further. So I think I'm at the T11-12 disc space with my marker. There it is. So that's 4-5, 3-4, 2-3, 1-2, 12-1. Go back north. Shot. So I'm verifying, that's good. I'm verifying that she has 5 lumbar vertebrae and the ribs start at T12, which they do, which is pretty standard. And we're at the T11-12 disc space. I need to get a view down the disc space. So try angling the fluoro a little bit so we can shoot down the 11-12 disc space. That's better. So my marker is on the left side at T11 pedicle. A little bit more and I think we're there. Shot. That's pretty good. I think we could do just a tiny bit better. Just the tiniest bit more. Are you comfortable? All right, good. All right. Well, I'm going to give you some numbing medicine, okay? You're going to feel that same kind of stick and burn, all right? Just a little stick and burn. I apologize. We're going to be able to put you to sleep soon, but I need your help, as you know. So, she's a good example of, we talk about this in medicine quite a bit, and it's a real phenomena. The interplay between anxiety and pain, and the pain is real, no doubt about it. But anxiety, as the levels of anxiety increase, the pain levels definitely go up. So shot. 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 get a lateral view, please. So we're trying to keep her calm and comfortable. I've done over 1,300 of these surgeries, and I can tell you, I need to see further back. So maybe bring the fluoro up, that's good. I can tell you how important the level of anxiety is when it comes to how patients perceive their pain. It makes a huge difference. All right, so I'm not seeing our needle just yet, so we need to go up a little higher. I want to make sure my trajectory is good. Yeah, you're doing fantastic, by the way. Just take nice slow breath. You see we're far away from the spine still. And I think I see 11-12 is just, if you draw a straight arrow through from the needle forward, will be just above the disc space. So I probably want to start just a slight bit lower. That's what I'm going to do. Are you comfortable? All right. You're doing great, by the way. Shot. 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 So I feel the facet joint. Give me an AP. So I want to use my AP to verify where we are. I believe it's 11-12. I could see the two ribs, and the bottom rib is 12. The top rib is 11. And we're at the, I believe, the facet joint of 11-12 on her left side. A little bit too medial. So I need to come a little bit more lateral. But otherwise looking good. Shot. You're doing great, by the way. Shot. Shot. Lateral. Where do you feel that? Yeah. So we're at the right level, which is good. We just need to sneak around this facet joint. Shot. You're fine. Just relax. You're doing fine. Shot. Shot. I know this is the worst part. Huh? Shot. Shot. You okay? We're almost done. We're going to be able to put you to sleep soon. Look, nice thing is you can see both lung fields opening and closing, so. Let's go lateral, AP. Watch your laser fiber. You're doing great. Just relax, okay? Still feeling uncomfortable? Huh? I know you can do it. You're doing great. So we're right on the edge of the facet. You can see it right there. Let's go back to a lateral view, please. And again, this is T11-12. Everybody in agreement? We're doing T11-12. Yes, yes. She has a thoracic disc herniation at T11-12. And it's causing problems for her with respect to bladder dysfunction. Sean? You're doing great. Just relax, okay? I'm almost done. Shot. Just in the back, correct? You're doing fantastic, I promise. This will be over soon. You comfortable? Shot. All right, so we're right there on the disc. I want to direct it medial. We're right on the herniation. Shot. So we're inside. This is the T11-12 disc. Are you comfortable? All right, just take a few breaths. We'll get you settled, and then we're gonna put you to sleep very soon, okay? Now, I know your back pain is, so let's just talk a little bit about her back pain for a moment. Your back pain is down here, right? Yeah. Do you ever get pain up in this area? What'd she say? Yeah, you get pain up here. It's just not as bad as the lower back, right? Yeah. So she contacted us for lower back pain in this area. She's already had a surgery. And let's just show you what we're about to do here. She has an incision, an old one, from here down to about here. I could see the scar, okay? Right there to there. That's from her laminectomy she had years ago. And they operated on the L5-S1 disc. The L5-S1 disc is probably around here. That's L5-S1. Now she also has an L4-5 disc problem. So her L5-S1 disc is completely collapsed. The L4-5 is right above it. And this is the area of her pain, right in here, okay? Now she has disc pain from a herniated disc at L4-5. And she has pain, I think, coming from her facet joints, which are right here. And we're going to treat her facet joints as well, okay? But she also has pain up here at T11-12. She has a herniated disc at T11-12 right here. And it's on the left side, but it's pushing on her spinal cord. The spinal cord comes here and it ends right about there. And then all the nerves come down off the spinal cord and go down into her leg. Just lay still, you're doing great. I'm just drawing on you. Those aren't incisions. Did you think I was cutting you? I'm sorry, we're drawing. You're my chalkboard. Yeah, but you're gonna enjoy it later because it's gonna all make sense to you. All right? So this is the spinal cord right here. And this herniation is pushing on her spinal cord. And it's causing her bladder is down in her pelvis in here. The nerves come off the spinal cord and go to her bladder. And it's causing her bladder to have dysfunction. And I can't go into the details because I don't want to talk about her medical history. But this has been undiagnosed for years and years and years. So her bladder has been not working properly, and she's been getting complications as a result of that. And I'll let her tell you about that if she wants to, but I'm not going to mention the details. But long story short, because the spinal cord's getting pinched up here at T11-12 from a large disc herniation, and she doesn't want to, you know, the only other way to fix these herniations right here would be to do a very complex spine surgery where we come in, we make an incision about that big from there to there, and we have to basically peel the muscle off the spine, mobilize it, and move it out of the way, and then you can actually skeletonize the spine, and you have to remove the facet joint and even take out part of the pedicle. It's called the transpedicular, even lateral extracavitary approach. Depends on, you know, what you do exactly. But then you got to take the herniation out. You got to put a cage in there. You got to take the whole disc out, put a cage, and then you're going to have to put screws and rods above and below. So you're going to have to put screws and rods from, let's say this is T11, 12. This is going to be probably T10, T11, T12, L1. You'd have to put screws and rods basically from T10 to L1, okay, on both sides. You're doing fine. I'm just drawing on you. I've been doing that lately, kind of help teach people. All right, so at this point, we've accessed the disc that we're going to fix today. And we're going to do, just to confirm, we've got the right areas. Are you comfortable? Do you remember what happens next? No. There's a little something we do before that. I've got to make sure I can see your tear and your herniation nicely. Okay? Shot? All right, good. I want to make sure that's T11, 12. So, do you feel anything there? Well, that's all right. Don't worry about it. This is not a painful disc that we're trying to fix. This is because it's pushing on your bladder. Can I see the MRI just one more time to make absolutely sure? Get rid of that white thing. What's that white mark right there? Yeah, that. Blocking the spine. All right, there we go. All right, so 5, 4, 3. No, don't move. Go back to where it was, please. I'll tell you when I want it moved. 5, 4, 3, 2, 1, 12, 11. It's 100% 11, 12 herniation. So we're definitely in the right place. And that's, I told you to get an AP. What happened? You just want to make me wait? And so we're going to get another picture, and I want to make sure that we can see that this is the disc between the two ribs. Everyone see the ribs coming off? The ribs come back and connect to the pedicle of 12, and then the one above connects to the pedicle of 11. So we're at the disc between the 11 and 12. It's interesting, if you look down lower, you can see the psoas muscle shadow coming off of L1. Okay, that's good. And let's just move a little bit south. Don't take a picture yet. Are you comfortable? We're going to put you to sleep in a moment. I just need one more thing to check. You comfortable? All right. Is that your typical back pain? South. How bad was that at the worst? 10? So that was a 10. That was L4-5. Get a lateral. You can go to sleep now. When you wake up, we'll be done with your surgery. Take your time. Put her to sleep. You did great. We're done. When you wake up, you'll be done. Let Patel know we're going to need him, and let Patel know we'll need him in 20 minutes, please. You can't be so close to Luis. Move further away. All right. Okay, count from 1 to 100 out loud for me, all right? You're doing great. Just calm down. Everything's going very well. So I'm going to start with her lumbar. Yeah, I'll come over there. And just to give you an idea of what we just did, so you understand. We checked this disc down here. I can't get into 5-1. It's got basically too much bone from her prior surgery, and it's blocking my access. And that's okay, because to me it looks stable enough. It looks like they may have actually tried to fuse it with her surgery. I don't think they told her that. Anyway, the L4-5 disc is causing 10 out of 10 pain. It's her typical pain she gets every day. So we call that concordant pain. That's the discogram I just did at L4-5. So I'm going to start by repairing the L4-5 annular tear, which is the source of her back pain, and removing the herniation that's there, which is the source of her leg symptoms. Then we're going to go up here and we're going to do the thoracic disc herniation. Now she knows that my experience to date in doing laser surgery, Deuk laser disc repair, which is a peer-reviewed, published, FDA-approved procedure. There's FDA, all the equipment and stuff we use is FDA approved. The FDA doesn't approve procedures, they approve equipment, instruments, implants, things like that. Everything's FDA approved. So we're treating this disc to get rid of her back pain. We're treating this disc to get rid of the herniation that's pushing on the spinal cord. I can't get 100% of either herniation, but what I can do, this one here, I'm probably going to get about 50 to 80% of the herniation, enough to get the pressure off the spinal cord. And this one here, we're going to fix and get rid of the pain that she's having down here. We're also going to do the RFAs later. RFA is a radiofrequency ablation. She has some facet pain on that right side. I think that's what she's feeling at 5'1". I think she felt disc pain at 4'5", facet pain at 5'1". We don't know what people are feeling from where until they actually come here, and we are able to do some of these additional tests and figure it out. We do a lot through telemedicine, but we can't do everything through telemedicine. Telemedicine doesn't allow us to physically examine a patient. Not yet. Someday, yes. It really will require having another person there during the telemedicine to really push on the patient in certain areas to see if those areas are causing pain and discomfort. The point is, it doesn't matter what pain a patient has. Incision, we can fix it. We just need to know where it's coming from, and that requires the patient to be physically here at Deuk Spine Institute for me to be able to do that. Hope you're enjoying the broadcast. If you have questions, feel free to ask. Right now we've got a guide wire going down to the disc that we're going to fix, and now I'm putting a dilator down. And I can do this with the patient asleep because I actually placed the original guide wire and needle, I placed it with her awake. By being awake, she's telling me if I'm getting too close to any of her nerves that I need to be aware of. Specifically, I'm worried about the L4 and L5 nerve roots. That's the L4 and L5 nerve roots. And by having her awake, she'll tell me if she's having pain going down her leg. Now you can see her body responding. I'm right on her herniation and the annular tear. I'm literally about to go through the tear. And this is the painful part of her disc. And what I'm doing right now is I'm just pushing on that annular tear, and it's causing her to react a little. I don't need any more anesthesia, but I'm making a point. These experiments on humans were actually done 100 years ago, almost 100 years ago, about 80 years ago, by spine surgeons like Dr. Cloward. He observed when he was doing spine surgery, when he pushed on the back of a herniation with his instrument, metal instrument, it created pain. And that pain was the same pain they get in their lower back. So he actually was the first to realize that disc injuries could be painful. Now, that research that he did 85 years ago has been ignored by neurosurgeons and orthopedic spine surgeons worldwide. They've ignored that. They say that disc injuries can't cause back pain, but they do. They cause what's called highly localized back pain. Localized, not diffuse, not nonspecific, but localized. Everyone nowadays calls back pain nonspecific. What nonspecific means is they don't know the specific cause. Look how she's moving now that I'm on the herniation. That's her pain. This is going to be the more painful part of the surgery, unfortunately. But that's why she's asleep for it. Okay? She is literally asleep. She is not feeling pain. She is just moving in a reflexive manner. Our bodies move reflexively away from pain. That's because pain signals go all the way down to our brainstem. They go up to our brainstem. And in our brainstem, those pain signals trigger behavioral patterns, movement patterns, like she's having right now. And so what she's doing is not conscious. Pain is a conscious perception. Okay, conscious means your cortical areas of your brain, your association and primary sensory areas have to be responsive. They're not responsive because of her sedative. So she's not consciously feeling pain, she's subconsciously feeling pain. And that subconscious response is being coordinated by the brainstem, the medulla oblongata, the pons, and using using basically parts of her brain that are very old and that respond to pain. Okay. So she's going to be moving a little bit. That's fine. I don't have a problem with that. We're inside the herniation at L4-5. And now we're going to put our suction line on along with our fluid adapter. We're going to move the fluoroscope out because I don't need it right now. Wait, stop. Get the suction line. Okay. I don't want to contaminate the fluoro with the back of my head. My head is, my hat and things on my head are not sterile. So we're going to move that sterile instrument out of the way. It's a piece of equipment. So can you all see this here, Sean?
Yes.
So our whole surgery is going to be done through a tube that is 7 millimeters in diameter. It's going through a 7 millimeter in skin incision. We're going to repair the L4-5 disc. Now, when it comes to the thoracic herniation, I'm going to use a different tube, a much skinnier tube. It's the one that I use for the cervical as well. You've probably seen it if you've watched those surgeries. And what I was going to say earlier is I've only done 6 thoracic laser surgeries in my entire career, 6 patients, because it's new. We've been doing cervical, which is the neck, cervical disc herniations, and lumbar for 16 years now at Deuk Spine Institute, endoscopically. But I only started doing thoracic disc herniations last year in 2020. And it started with a few patients that had so much pain in their thoracic spine, in their middle back area from a herniated disc that nothing we treated them with worked. We tried epidurals, we tried facets, we tried everything, trigger points and medication and everything short of surgery. And it didn't work. And they were desperate. So they begged me to do laser surgery, and I was really hesitant because it's riskier than doing lumbar or cervical, and the risks are substantial. And so I didn't want to do it. And I told them no for a long time. And I saw how much pain they were in and how, unfortunately, how desperate they had become. And they basically told me that they would rather die than live with that pain. And I knew I had to do something at that point, so I did. I did the laser surgery, and lo and behold, we did it, and we didn't have a complication. It went very smoothly, better than I ever expected. And the patients, all 6 of them, had 100% elimination of their pain. By the way, the pink stuff is the granulation tissue from chronic inflammation. We just saw that. She's moving just a little bit. But again, not conscious, subconscious.
We have a question.
Yes.
One of our viewers is wondering, how reliable of a measure is a discogram? Are you sure that it won't make a happy disc painful because of the increased intradiscal pressure?
Yeah. So the question is, how reliable is a discogram? So there's really 2 types of discograms, okay? There's evocative discograms, otherwise known as provocative discograms, and then there are just chromodiscograms. Chromodiscograms are when you're not looking for a pain response, you're just injecting dye into the disc. And that's rarely ever done. Let me just see, we got something on the lens. Hold that. You're seeing what he's doing? I'm trying to clean the lens a little bit before I answer the rest of the question. Let me see here. That looks pretty good. Okay, good. So evocative discogram is not something that we at Deuk Spine created. It's been around for many years. And the idea is that you're injecting a small amount of fluid into the disc and seeing if it elicits the response of pain. And the idea is not that the pressure doesn't cause the pain. It's actually pressure and the fact, most importantly, that the disc is actually inflamed and the source of the patient's pain. So let's take some different scenarios. Scenario number one, there's a normal disc. If you do a discogram on a normal disc, and you put a tremendous amount of pressure, tremendous, like at least 3 or 4 times more than what I just do normally, the patient will have zero pain. The disc is not painful. They will have no pain whatsoever. They won't even notice what you're doing. They might feel a slight amount of pressure at most, but they won't have pain, okay? So normal discs are never painful no matter how much pressure you give on the discogram. Now let's take a herniated disc that is not painful. It's not a painful disc, but it is herniated. And let's do a discogram on that. Again, you put the needle in and you inject the dye and you put it under massive pressure. There will be no pain, no pain. All right? There's just maybe pressure, but no pain. So let's take the final situation. The painful herniated disc, like this patient has. In that situation, you don't have to put that much pressure, just a little bit. Maybe 1/5 as much pressure as you were doing on the normal disc and the painless herniation disc. And you will get a pain response. And most importantly, the patient will tell you, that is my typical pain. That's where it's located. That's the quality of pain I typically get. Now, it won't be the same intensity, but it will be the same quality. Does that make sense? The same quality. So that's what we're really looking for, is the quality of the pain, but we also want to know just how bad it gets. So most people that have a painful disc in their back, they adjust their day-to-day routine, their activities, their lifestyle, to where they're not putting pressure on that disc. And the way you avoid pressure on a disc is by avoiding bending, by avoiding twisting, by avoiding picking up and carrying things. So basically you restrict your physical activities to basically not cause pressure on the disc that's painful, okay? And it's effective, but it robs you of your quality of life, because now you can't play sports, you can't go to the gym where everybody else is going. You really can't do much of anything on your feet, because being on your feet pressurizes your painful disc. So people that have discogenic pain, pain in their discs or spine pain, are generally very sedentary, and they've taken their life and they've modified their behavior and activities to avoid precipitating pain. All right? So I'll give you an example. Same thing happens with hip. You know, if you have arthritis in your hip or your knee, and that arthritis is causing hip or knee pain, you know, you stop being active and you just kind of sit around, because any kind of running, any kind of fast walking, any kind of physical activity is going to cause that knee or hip that's inflamed. It's going to cause the inflammation to get worse, and it's going to cause worse pain and stiffness. And so people with disc injuries that are painful, people with knee or hip problems, any kind of a joint issue, and the disc is a joint, any kind of a joint damaged with inflammation is going to restrict their activities, because they're going to be forced to do less. They don't want to aggravate the pain. They don't want to bring the pain on. They basically want to take it easy so they don't get the pain. That's the problem. So to answer your question, a normal disc or an abnormal disc that's not normally painful will not cause pain during a discogram. And that's why we need the patient awake, so the patient can tell us, yes, that's my typical pain that I get every day. Just not as bad maybe, because they're restricting their activity. All right, we're just about done. This is the tear we've been repairing now while I'm talking. Almost done with it. Needs a little bit more. That's a great question, by the way. Thank you for asking. Does Dr. Patel know we're going to need him soon?
Yes, sir.
All right. Probably another, I would say 20 minutes at this point. I'm guessing. But at least 20 minutes. You have all the stuff he needs? Dr. Patel is going to do the rhizotomy or RFA. I don't do those, typically. He's far better than I am at doing it. and I want to make sure it's done properly. Oh, by the way, you can see a little vein right there. That's a vein. That's what a vein looks like in a real human that's alive with blood flowing through it. This is the tear laterally. Notice how I reverse to 180 degrees and I'm looking laterally in the disc on the back side of the scope. You don't want to leave a lateral herniation in the foramen. It's just bad form. So you want to make sure you get it all. I know this looks big, but keep in mind from wall to wall, it's about 6.3 millimeters. So it's very, very narrow. It looks super wide. It looks like we're doing a lot here, you know, but it's just such a small little space that we're working on. This is really the tear in the back of the disc that's allowed the jelly to come out. So just about done here. Then we're going to go to the thoracic. Okay. The blue stuff, by the way, is the jelly, the nucleus pulposus. It stains blue when it's degenerated. So I want to try to remove as much of that stuff as I can. I'm not going to take that little vein. You can see veins have a very thin wall, and that has a thin wall. What you're seeing, the red, is little red blood cells passing through. And that's how amazingly zoomed in this scope is. You can almost see individual red blood cells, like liquid, red liquid gushing through there. Okay? All right. Pretty cool. We don't want to bother that little vein. This is the last part of the tear I need to fix. I can see some of the fibers of the posterior longitudinal ligament in there. But you can see the blue jelly is just squeezed out through that tear. Let's see if I can get a little bit more medial. Any questions?
None others.
Okay. Hopefully you're enjoying the live stream of this spine surgery from Deuk Spine Institute here in Melbourne, Florida. And our patient is visiting us from Canada. Now, she brought me honey because they farm bees and they make honey up there. It's God's country up there. And basically, to tell you the truth, she has another family member who had surgery here from Canada about 2 months ago. And I'm sure he's watching. And basically, they both farm bees and they both produce honey. And they're related. I won't say how they're related, but they're related. And they both make their own honey. They both farm their own honey. And basically, they compete against each other for who has the best honey. Now, my other patient brought me some of his honey. He and his wife did, and it was amazing. And then this patient brought me some of her honey, and I talked about it at the beginning of the surgery. She asked me to do a comparison, whose honey is better. I mean, of all the things to do, right? So I'm sure her brother is listening right now, or will be. And I told her my feelings. My daughter and I both did taste testing, and we both agreed. Her family member's honey is much smoother, almost like butter. It's amazing. There's no crystal sugar in there. It's very smooth and quite delicious. Her honey has an amazing flavor, and she says it's from canola. We're basically done here. She says it's from canola, which I didn't know that bees, eat canola flowers, but it makes perfect sense. Yeah, it looks good. I'm happy with that. Don't think there's anything else I can do. Let me see the laser. I'm going to do a little bit more. See if I can get a little more of this. I don't know that that's necessary causing a problem, but I don't want to have to come back again. So I want to just get another millimeter or half a millimeter of this roof out. So I think what I'm trying to say is that both honeys are remarkably good. And they're both natural. Nope, I don't think there's any preservatives at all. But they're very different honeys. Her honey has a very interesting flavor that I like. And her brother's honey is incredibly smooth and buttery. So, whose is better? I honestly can't say. I just say they're both exceptional. And you should check them out. If I find out the name, maybe your brother can post the name of the farm. I don't think they even sell this stuff in the stores, so you probably have to write them if you want to buy some from them. But they're beekeepers, and they have hundreds of hives, and they're up in Canada, and I'm just so impressed with what they do. I love it. I love honey, I love bees. I have a lot of respect for those animals. So, all right. Let's see here. That's it. I think we're done. That looks good. Just clean up that tear. See what I mean by a tear? Yeah. So, looking good. Looking good. We're done at the lumbar. Of course, we're going to do the RFA later. I'm just sucking out some of the liquid. Is there no suction here? No, there's not. There's no on this tube. Okay? Come on, get it off the bag, get it on the tube. Ay, ay, ay. I know this is something that we've never done before.
We have a question.
Yes, it's good that you have a question, so I don't have to say anything nasty. Sometime this century.
One of our viewers on YouTube is saying, I asked my surgeon about this procedure versus a fusion at L5 that
Hold on one second. Luis, this is your home. Make sure that people treat your home with respect. Go ahead.
One of our viewers on YouTube says, I asked my surgeon about this procedure versus a fusion that he has me scheduled for at L5.
Yeah, so Sean, your voice is too soft as always. Just turn the volume up a little bit, please.
Is that better?
Once more.
How's that?
That's good.
So the viewer said his surgeon has him
There's no
scheduled for
suction.
an L5 fusion. He asked about this surgery, and his surgeon told him that he could guarantee he'd be back within a year for a fusion if he got laser surgery. Why is that?
Oh, I love it. Thank you for saying that. So one of our viewers is saying his spine surgeon, who doesn't do laser surgery, doesn't know how to do it, has no clue anything about laser surgery, is guaranteeing the patient, his patient, that if he goes and gets laser surgery, he's going to need a fusion in a year, within a year. So your surgeon is saying the truth, and he's also lying at the same time. There is no one laser surgery, okay? When you talk about spine surgery, we're not like a car. We're not like a Toyota Corolla 2021. Whether you get it done in California, or you get it in New York, or you get it done in Chicago or Florida, it's all the exact same parts and same thing. Same electrical, same function, same gas mileage. You're not getting a car when you get laser surgery. You're getting the work product of a doctor. Now, laser surgery, spine surgery, done by me, and where I've peer-reviewed and published it, is a procedure that works. Now we have it. So you don't get lunch today, by the way. Okay? When you do stupid things in my operating room, you have to have a punishment. I can't take your pay away, but I can deny you benefits. Okay? Yeah, I want 100% focus, attention. Your job is not hard. Your job is, on a scale of 1 to 10, a 0.5 to make sure the suction's working. My job is hard. On a scale of 1 to 10, I'm at an 11 and a 12. So I don't need somebody who's supposed to be doing a 0.5 level difficulty job to distract me from my 10 out of 10 difficulty job. You understand? I need you to be on the ball, focused. Don't be reactionary, be proactive. You understand the difference? Do you? The difference is you plan in your mind every step of every minute that you're here. You understand? You're aware of all the things in the operating room that need your attention, from lights, sounds, equipment, plugged in, turned on, operating at the right level and performing correctly. That's your job. So you've got to always be assessing what's going on around you to make sure everything is performing correctly. Would you throw a steak on the barbecue and walk away for 30 minutes? No? How about 20 minutes? How about 15? How long are you going to walk away for? 5 minutes, that's right. That's about all you can walk away for, because any longer you're going to burn it. You understand? And it needs constant assessment, constant monitoring, constant changing, and interaction by you and that steak and that barbecue. Why do you think the operating room is any different? You think these equipment are simpler than a barbecue? They're not. They're more complex. That's why you're a nurse. You're a licensed healthcare provider. That's why you have to be here to operate this stuff. You have to be on top of it. Okay, so you want to know the difference between why your surgeon says laser surgery won't work. Your surgeon's correct. Most doctors that do quote-unquote laser surgery, they're not doing what we do. Actually, none of them are. What I do here, what works, what takes pain away, is exactly what I do. It's not reproduced or done by anyone else. So if you go to, and I'm going to give you an example. There's a group. Do we inject the steroid?
Yeah.
All right. Back off. I'm not ready for you. Are you paying attention? Do I have to get on you too? You don't see this out, do you? So there's a group here near us that has seen how successful our procedures are. And now they're advertising that they do laser spine care. Now they do this laser by just putting a laser. Can you see me, Sean?
Yes, we can.
They literally put a laser. Let's pretend this is the laser, okay? You saw what I did. The laser's inside the disc, repairing it. They take their laser, it's like a wand, and they put it on your skin and they rub it around like this. You see what I'm doing, folks? Everyone see this? They do this, okay? And guess what? The patient's done. They get up, they go home, they feel good for like 20 minutes because they're rubbing their skin with a laser and warming it up and getting circulation going. But then an hour later, their pain is still there. Why? Because they never fixed the problem with the laser. All they're doing is a gimmick because they're not surgeons. They don't know how to fix a disc herniation with a laser. They're just like technicians who want to make quick bucks off of people by basically just lay still, you're fine. They want to make a quick buck, so they tell you they're going to do laser therapy for your spine. All right? It doesn't work. And your surgeon would be correct. If you go to those people that just, what? You want to go pee? Yeah, you can go pee. We'll just clean it up. I thought, did we take her to the bathroom before?
Yes, you would.
All right. You went to the bathroom before. You should be fine. You probably just have a sensation. All right. We're going to put you back to sleep. We need her back asleep. All right. So what I'm getting at for the person that asks about the laser, it really bothers me because it's extremely deceptive to the consumers. It's basically fraud. They're giving you a technique that doesn't work. It will never fix your problem. So if you go to those people that do bad laser stuff, you're definitely going to be back for a fusion, okay? At Deuk Spine Institute, our patients don't get fusions. 1% of my laser surgeries, 1 in 100, will re-injure their disc and have a new herniation in the same place I did surgery, okay? Those people, half of them would go on to have a laser surgery a second time. The other half will just do a fusion. So is it true that even with the very best laser surgery in the world, which is the Deuk Spine Institute laser surgery you're watching right now, is it true that the patient would need a fusion in a year? Yes, it's true in in 0.5%, so 0.5% of patients. I'll give your surgeon that, but it's not true in 99.5% of patients. 99.5% of our patients never get a fusion. We've been doing this 16 years. Our patients that have this surgery, it lasts. We have people that had it done 16 years ago. Their pain is still gone. So no, you won't need a fusion if I do your laser surgery. You will need a fusion if someone else does your laser surgery. It's just that simple. So I hope that answers the question. I know it's a complicated answer, but you need to know why I say what I say. All right, take a look here, Sean. This is the incision we did, okay? Where's the marker? Can you see this, Sean?
Yes, we can.
All right. Her old disc surgery incision was from here to here. Look at that. My new one is this big. It's 7 millimeters. It's tiny. And we didn't take any bone out of her spine. Unlike her last surgeon that took bone out of the spine. All right, I don't feel any hematoma. It feels good. We're going to get started in the next one. This next surgery we're doing, come on in with the fluoro. The next disc we're doing is thoracic, for those of you who joined us late. Our patient has traveled here to have her thoracic disc herniation repaired and her lumbar disc hernia, her lower back pain and lumbar disc herniations repaired. So we're actually doing two different parts of the spine, thoracic and lumbar. Now the lumbar's done. I did that first, and I'm going to do the thoracic next. I've already placed the needle transforaminal in the thoracic spine, and I'm going to tell you I don't need an AP, I need a lateral view. Okay? I'm going to tell you right now, all surgeries that I do, even as a 25-year neurosurgeon, trained at the very best training program in the world in Gainesville, Florida, with Dr. Al Roten, Art Day, Rick Fessler, among other doctors. Some of the best neurosurgeons in the world at my program that trained me, which is why I went there, by the way. I still get, I won't say nervous, but I still worry every surgery I do. I still worry about having something not go right, being in the wrong place, doing the wrong thing, having a complication. So even though I've done 1,300 of these laser surgeries, I still worry about complications in every single one of them. And so even though I talk to you and educate you as I'm doing what I'm doing, I'm still, part of my brain is extremely focused on making sure nothing bad happens. Every little millimeter, half millimeter that I do. Okay, so I want you to get inside my head and understand, as a spine surgeon, as a neurosurgeon, I'm extremely conscientious about what I'm doing. Now take a look at the back of the vertebrae of T11. It looks rotated compared to T12. You see that? So we need to do something with the orbit. Let's try moving a degree one way than the other, just to make sure we can correct that. I want to have a parallel back of the, I think that's better. What do you think, Luis? It's hard for me to tell. Can we do a little more? And I'm looking at the back of the T11 vertebrae. I'm just trying to line it up properly. All right, that's worse. So go back to where you were, maybe. It's not perfect, but it's pretty darn close. I like it. Notice, looking at the wire passing by the facet joint, behind the disc at T11-12. Look at the gap between the T11 inferior facet and the T12 superior facet. Okay? What is that gap? Well, honestly, that's probably an injury to the facet joint from a long time ago. She's had this disc problem a long time ago. She may have fallen or gotten into an accident of some type. Even as a child, this could have happened because she's had urinary problems for many, many, many years, just misdiagnosed in Canada. And I'm not saying anything bad about the Canadian healthcare system. This stuff happens in the United States just as often as it happens in Canada, trust me. But whenever somebody has urinary issues, you have to look at the spine and make sure there's nothing pushing on the nerves or spinal cord. In her case, there was. I got to be honest, I don't see that very often, even as a neurosurgeon. It's rare that I see bladder dysfunction in a patient as a result of a disc herniation. So this is an uncommon situation. We're going to go ahead and remove her needle, but I'm going to watch the fluoro and make sure the guide wire stays in place. I don't want the guide wire advancing, so I'm going to remove this thing slowly, little by little. This guide wire is basically this quote-unquote saving grace of the surgery. See, I wouldn't be able to do this without this guide wire. The guide wire is going to guide my instruments, which are big and dangerous, to the spine. Shot. Don't move. You're doing fine. The guide wire, you can see the needle now. The tip of the needle is just about in the foramen. Now it's at the back of the disc. So I'm watching. There's a difference in caliber. If you look at that last x-ray, right where the disc ends in the back, you can see that there's a needle there. Now the needle is almost past the facet joint. It's in the foramen. You can see the tip of the needle there. It's kind of a difference in caliber. The guide wire is skinny. The needle is fatter. Shot. All right, so now we're at the level of the facet. I'm just slowly backing this needle out, and I don't want the guide wire to move back. If you're a surgeon doing this surgery and the guide wire moves out of the disc, you must stop, wake the patient up, and start again by placing a new needle. Okay? All right, now I've got the needle out. I've got the guide wire in. You all want to see this? It's pretty cool. We're making history, okay? This is our 7th thoracic disc herniation patient we're operating on. Can you see, Sean? All right. Sean, your voice is really softened. So I'm going to go ahead. Sean, are you able to see the back here?
Yes, we are.
Thanks. This is the left side. We're at T1112. We're transforaminal with our guide wire. I'm going to make a stab incision. This is a 4 millimeter incision because our tube is 4 millimeters. Now I'm not going deep. I'm just going very superficial with the, I want to get through the skin basically. That's what my goal is with the 11 blade. Now for the lumbar we use the 7 millimeter tube. For the thoracic and cervical we use a 4 millimeter tube. That's the diameter of the tube I do the surgery through. It's called the tubular retractor. I'm going to be using this dilator. It's about 3.6, maybe 3.5 millimeters in diameter. It's very skinny, okay? It looks like a metal pencil. This is going to spread the tissues all the way down to the disc, and then I'm going to place the tubular retractor over this. So here we go. Passing down, and our patient is asleep. Shot. You got to watch the tip of the guide wire, make sure it doesn't advance. I don't want this thing going past the disc. So here we go. Shot. Yep, now I'm watching the guide wire. It's not moving, which is good. You always got to be mindful of the guide wire. Actually, the tip of the guide wire is the thing you got to watch the most at this point. Now I'm in the foramen with the tip of my dilator, and I'm advancing it through the foramen just underneath the exiting T11 nerve root. I'm on getting close to the herniation. I'm on the left side. Okay. Shot. Want to make sure the guide wire is not moving. Sometimes the guide wire gets pinched and it moves. All right. And let me just show you. Shot. Let me show you an AP view. Go ahead. So we've been looking at a lateral view. By the way, the incision from the prior area in the lumbar is good. Tell me when you're ready and go ahead and get a good shot. And we're going to just take a different angle here. Yeah, nice. So I'm right at the back of the disc, and look where the tip of my dilator is. I'm right at the mid-pedicular line. That's where the disc is. On the AP view, we've got the spinous processes almost centered. Notice how there's a little bit of scoliosis, just a little bit, because the spine is slightly twisted. Go ahead and rotate the fluoro, just a little bit, like a degree. Maybe the other way. Shot. Let's see what happens. I want to get the spinous processes centered. Nope, you were right. It is the other way. The opposite of what I told you. Yeah. Try that. All right, that's really good, actually. Really good. Yeah. Now, the amount of scoliosis she has is so minimal. It's only a few degrees, so it's nothing to write home about. But look at the pedicle of 11 and 12. Look at the ribs. The ribs go in, and they touch the lateral side of the pedicle. We are at the mid-pedicular line. We're right at the disc. We're about to go in and get this herniation cared for. Go lateral. We know from her MRI this is a T11-12 herniation. I'm just going to count one more time. You see how many times I count? Many, many times just to be sure. 5, 4, 3, 2, 1, 12, 11. There it is. Big herniation at 12, 11. Okay, so here we go. This is the last disc we're going to fix. Okay, that looks good. I'm going to advance this dilator into the disc. How's she doing? Good. Shot. As I do so, I'm twisting it. I'm going through the herniation and the tear. I'm trying to push the herniation back into the disc. That's one of the advantages of this technique. Now remember what I told you earlier. If we were doing this surgery, if any other surgeon but Deuk Spine and Dr. Duke Mage and myself, the pioneer of the endoscopic transforaminal surgery, the Deuk laser disc repair, if we were doing any other type of surgery other than the Deuk laser disc repair, this patient would have a huge incision, possibly have her ribs taken out, one of her ribs taken out, just to get access and fix this disc herniation. So this is a new technology and a new technique that I developed and pioneered for thoracic herniations. And this is our 7th patient we've done. So we're inside the disc now through the tear. I'm taking the guide wire out. It's safe to take it out. And I'm going to just put this dilator in a little further just to anchor it. All right? She doesn't like that. And now I'm going to put my tubular retractor. The entire thoracic disc repair surgery, the Deuk laser disc repair, will be done through a 4mm tube. You all see the tube? Sean?
Yes, we can.
Yeah. So when I ask, you're the one who answers, Sean. All right? Just in case you're not sure who I'm talking to. I'm talking to the audience, but you are the audience, Sean. You can see what they can see. So I need you to respond. Okay? We're just going to wait for you to respond.
All right.
Okay, so here we are. The dilator is inside the disc. The tip of the tube is about to enter the foramen. And we're passing the spinal cord. We're going in. There's been no bleeding. It's very safe. Shot. I'm very happy so far with the way things are progressing. Our patient is completely asleep. We're at the back of the disc, just lateral to the posterior longitudinal ligament. Is that my shot? All right. Again, watching the dilator, making sure the dilator doesn't go any further. Shot. All right, I think that's pretty darn good. Take that?
Yes, sir.
Yeah, so I've taken the dilator out, and we are now inside the herniated disc at T11-12 on the left side, which is the side that it was on. And we're going to go in there and remove this disc herniation, okay? Now, for those of you who think removing a disc herniation is you get one big chunk of herniation and pull it out, that's not how it is. It comes out in little pieces, and so don't expect to see a big something that looks like a slug, all right? That rarely ever happens. I get excited when those things happen, but I don't expect that to happen today. We just want to get it out. It's probably going to come out in several pieces. Okay, so just to show you what's going on, everyone see this? Wait, keep the light on for a minute. Sean, can you see?
Yes, we can.
I don't think I've talked to our audience about the endoscopic rig that we use, but it has a light source here, the blue cable, and it basically, y'all see that?
Yes.
It sends a lot of light through the scope down to the end using fiber optics. And then we have irrigation. So irrigation is basically fluid. You all see the fluid? That fluid gets pushed out the end. I have it off right now. And then, of course, you have the camera right over here. And the camera lets us see on the back side of the scope. You all see the camera there?
Yes, we do.
See Luis's face? Where is it? He's hiding from us. There's the laser fiber. So, anyway, Luis's head's too big for me to capture with this camera. All right. Gotta have some fun. Right? You rather my mouth be laughing than chewing flesh. All right, yeah. I thought you already put that kind of stuff in. What happened? You ready?
Yeah.
Oh, you switched scopes, but still, have it ready. And now, of course, our laser fiber has to go in. So, there it is. All right? So now we're going to go down the rabbit hole, and we're going to remove the herniation at T11-12. Our patient is still sleeping. Now, mind you, she is asleep with propofol sedation, which is amazing that we can do this kind of surgery with this kind of anesthesia and not have to intubate her and put her down with a tube and a ventilator. I need the light down, probably 2 clicks. It's too bright. Can you help me with that, please, guys?
Go down, it's looking a little.
Yeah, that's good. Let's, I may need a little more, but we're going to get started. Laser on.
Ready? Ready?
You guys ready?
Yes. Laser is ready.
All right, so this is part of the herniation. So why is the laser so amazing? Because you couldn't take this herniation out with standard instruments unless you had a very big hole to work through. But using, you see the calcium and the scar tissue, the golden color? That's all abnormal. This is all part of the herniation right here that we're seeing, okay? It's all part of the herniation, so far so good. You just can't get this surgery done with this small of an incision using normal surgical instruments like pituitary rongeurs, Lexel rongeur, grabbers, biters, metal grabbers, things like that. The laser allows us to do this surgery in a very minimally invasive manner that we wouldn't be able to do otherwise at all. We just wouldn't. So you can see the undulations of this piece of herniation here as I'm zapping it and shrinking it basically with the laser. Shrinking the herniation. Because what's happening, folks, at the tip of the laser, it's too fast for your eyes to see. What's happening is the laser is pulsing and delivering a little burst of energy. If I were to take this tip of the laser and put it on a piece of steel or metal, it would literally melt the steel. That's how much energy is being delivered right now to this disc. It's massive. It's massive, but you can't see it because, oh, look at that. Look at that herniation. Beautiful. That's nucleus. Oh, you want me to grab it? All right. Luis wants me to give him something, a sample to send off to the pathologist. They got to feed their kids, you know. Here you go. Here's a piece of herniation. So I'm trying to grab pieces out, but let me show you. Turn the light on for a second. Take a look at this, Sean.
We can see it.
You see the grabber, right?
Yes.
This is so ineffective. It doesn't work. This is what you do when you do open back surgery. You use a tool like this, a pituitary, to remove herniation. It just can't grab it. It doesn't have enough force. Even the normal ones, the big size ones, they can't grab it and pull it out. And it just falls apart in the mouth, like it breaks apart. It's almost like cutting it. It's like trying to take out cottage cheese with that thing. It just doesn't work. But when I use the laser, we just blast the herniation. It vaporizes it. It breaks it up into little pieces. Okay, that's what it does. Little pieces. And those little pieces then are floated out with my fluid, the irrigation. Okay, so the irrigation is a very important part of the surgery. There's a big piece of herniation right there. But it doesn't want to come out. You see, I put the grabber in, it wouldn't come out. So you got, oh, another herniation. Look at that. It doesn't surprise me. This is a pretty good sized herniation she's got here. So I'm not surprised we're getting a lot of the herniation fragments kind of presenting themselves into the tube. Any other questions, Sean? It's wonderful. This is going so well for her. I hope this works for her. I really do. I expect it to.
We have a question from a viewer on Periscope.
Sure.
They're wondering, after surgery, does the annular tear heal back to similar strength as it was before the injury?
Oh, thank you so much. That's an incredible question. Incredible question. So the question is extremely insightful. This person who asked it clearly understands the pathophysiology of this condition or disease, which is first there's a tear in the wall around the disc. That's called the annulus fibrosus, or annulus for short. There's another herniation. So that tear happens, and then a piece of jelly, it's basically hydraulic jelly, you know, that God put in our spines to cushion our bones. So when we move, the bones aren't rubbing on each other. It's a joint, you know, a joint between two bones, all right? And the question was, so if you do this surgery, does the annular tear, the thing that allowed the jelly out, the first event, the initial traumatic event, the first injury to the disc, does it actually heal itself? The answer is yes. Yes, it does. It will heal itself, and in 1 year, it will be 85% of the strength of a normal uninjured disc. 85%. So you never go back to 100. That's a fact. The best we can do is about 85%. Now, oh, look at that massive herniation. Just mushroomed out. I'm going to try to grab some of it. Now look, the whole thing that I do right here with Deuk laser disc repair that nobody else does is I debride the annular tear. I clean up that tear so that it will heal. If you don't clean the tear up with the laser, and it's called the debridement, it won't heal. It won't heal. And that's why these people have so much pain. It's coming from the annular tear that's trying to heal. And remember, the first step of healing is inflammation. Inflammation. When you have a pimple on your face, it's an inflamed hair follicle, or a little sweat gland or hair follicle. It's inflamed. Think about how painful that little pimple is. And these disc herniations and tears are literally 10 times bigger. So imagine a painful pimple 10 times bigger in your lower back. That's what this disc herniation is, okay? So the answer to your question is yes, the annulus will heal after the Deuk laser disc repair. But this is the only surgery in the world that does an annular debridement.
Lights on, please.
And of course, there will be people copying me in the future, which is fine. I don't mind it, as long as I'm credited with the discovery. And they will also be debriding the annulus, okay? But the fact of the matter is that it's the annular debridement that is the most important step in this surgery. And no other surgery in the world does annular debridement. They do a discectomy, they don't do an annular debridement. But the annular debridement is 100% necessary for the disc to heal properly and get rid of the back pain, neck pain, whatever pain it is you're having from your disc. Gosh, this is all, it looks, see how thick, how tough and thick it looks? That is collagen. That is scar tissue, basically, from chronic inflammation inside this herniation. And that's all driven by the nuclear material, the herniation itself, stimulating inflammation within the annulus, which then grows into the disc at times and creates scar tissue deep into the disc. You're doing fine. She's a little light, so that's fine. I need about 5 more minutes. Will you let Dr. Patel know? I'm expecting 5 more minutes. Could be longer. Man, just more and more of this herniation just keeps coming. Oh, there's another piece right there. Look at that. Actually, I need 10 more minutes. I apologize.
10 more minutes.
I need 10 more minutes. I haven't even started pulling the tube back, so I suspect I'll need a good 10 more minutes. I'm going to rotate this, go the opposite direction. This is the lateral part of the disc herniation. It's towards me. I'm standing on her left, so it's coming towards me. But yeah, this is looking good. We're making some progress here. See how elegant the laser is? It's just so precise to a half a millimeter. You know, the actual depth of penetration of the therapeutic part of the laser is half a millimeter from that tip. So once you get past half a millimeter, you don't have really anything to worry about in terms of energy delivery because it's in liquid, okay? Do not try doing this in dry. If you do this in dry without liquid, you're going to end up doing a lot of damage. So this has to be done in irrigation, which we're constantly flowing through, and it has to be done with cold irrigation. We refrigerate all of our irrigation. Okay, coming up, this is more of that same herniation. We're getting closer to the surface. She is going to feel this more because we're getting closer to the part of the disc that has pain fibers. Guys, I'm seeing air bubbles. Yeah, well, thank you for being attentive. All right. Don't touch this. I don't need to feel your fingers. I need to feel the spine. Okay?
Yes, sir.
That's what guides me. Uh-huh. That's the annulus. I'm getting close to the what's called the posterior ligament. Again, we're inside the disc herniation here, and we're removing the herniation. And look at the golden color, the golden yellow. That's calcium inside the herniation, inside the annular tear. And that's there because this has been going on for a long time. And it's calcified. All right? I didn't do it. It's just calcified. 12 o'clock. My laser fiber is always going to be at 12. And that's towards the spinal cord up there. We just have to be really careful since we're so close to the spinal cord, right? We don't want to do anything. And I'm just removing herniation medially towards the spinal cord. And what I'm doing is I'm debulking the herniation. Basically, getting rid of mass. It's the mass of the herniation that's pressuring onto the spinal cord. And I want to remove that mass effect. It's called mass effect. I want to remove the mass effect, the pressure, onto the spinal cord. Basically follow the tear right on out. These fibers don't look too bad. Now this is where the base of the herniation was sitting, okay? Just so you understand. We're passing through the annular tear right now. And that's what we're cleaning up. And I'm I'm debulking the herniation at the base. The 12 o'clock position is midline. And I'm slowly bringing my tube out. So we'll be out of the disc very soon. Okay? And we'll be done. There's some herniation right there. The nice thing is, once you start debulking the herniation, you actually create a cavity, and it becomes what's called a path of least resistance. So the herniations are almost always under pressure, okay? And so once you create that cavity, then the herniation itself wants to move back into the cavity. And then it makes it easier for me to take it out. The good thing is I have my laser fiber coming off at 12 o'clock, so I know if I look at my laser fiber where it is relative to her back, I know exactly where I'm at. Does that make sense? Yeah, it's amazing. Almost done. 2 minutes. Is Patel around? Huh? That's fine. Just about ready for him. It's interesting, the thoracic discs has a lot more annulus than lumbar. I never knew that until I started doing these. The amount of annular material is much greater in the thoracic spine. Okay, just about done. It's looking good. Remember, what? Thank you. This is not we're not doing this in her case for pain so much. We're doing it to restore function if we can. And she knows there's no guarantee that this is going to work. But it's the best treatment because she has this herniation that was just pushing on her spinal cord, causing damage to her thoracic spinal cord. And now it's gone. Mostly. It's all part of that. And so I'm hoping that it helps her. I expect it will.
Gary, 4x4 steady strips. Can you go ahead and here, please? Thank you.
It's all annulus, by the way, in case you're wondering what those beautiful white fibers are. Annulus fibrosus. All right, just about out. You can see the crisscrossing pattern. For those of you that are anatomists and you enjoy the anatomy, you can see the crisscrossing pattern of these annular fibers. They literally crisscross. And you could read about that in the anatomy books. It's been a well-known fact for years. Now we're outside and we're pretty much, I'll do a little bit more here and then we're done. Yeah. incredible. Absolutely incredible. All right. Is Patel here? We're done.
Lights on, please. Scope off. Laser standby. Off. Yeah, excellent. Yeah, off, please. You.
Okay. So, we're done with the surgery part. Dr. Patel will come in and take care of the interventional part. I'm going to remove this tube. Can you all see this, Sean?
Yes.
So we've had,
Yeah.
remember our first incision for the lower back was there. The muscle feels good. Now we're going to take this tube out as well. And again, we've done this spine surgery through what's called tubular retractors. And those are basically very tiny, skinny little tubes, which normally you cannot do surgery like that unless you have endoscopic ability. So you can go down the tube with the endoscope, and you have these instruments that are designed specifically for endoscopic surgery, which we have. They're all FDA approved. And we're able to do this endoscopic surgery with just tiny incisions. Are you ready to look at this incision, Sean?
Yes, we can see it.
All right. So take a look. Look how small, 4 millimeters. Okay. All right. Any questions from our audience?
None others currently.
Excellent. Let's get one. Let's get a quick fluoro real quick. Thoracic region. An AP. Full lung fields. You're still going, right, Sean?
Yes, we are.
Yep, you can keep going. Tell me when you're ready in your position. A little bit further north. Further. I want you center. Yeah, that's good. Tell me when you're ready. You ready? And shot. Beautiful.
It's good, Gary. That's fine.
Try to zoom out a little
Yeah,
more.
good.
Oh, yeah, okay. Are you sure? Yeah, that's zooming out. You're right. Shot. All right. Look good to you? Look good? Looks good to me. All right, let's get fluoro out. We're going to go ahead and put the Band-Aids on. And yeah. I'm going to head over there and answer questions. So go ahead and type your questions up, folks. We've just done an 11-12, T11, T12 disc herniation repair with the Deuk laser disc repair, done endoscopically through a 4 millimeter incision, Raytech off. And then we did the L45 Deuk laser disc repair. I couldn't get into L5S1 because of the prior surgery. Had a bunch of bone growth there. But I think we're going to be okay because I think most of her pain at 5-1 is facet, which we're dealing with. Hi, Dr. Patel. So just 4-5-5-1 on the right, correct? Yeah. Everything else went well. I'm going to call our blood loss 3 drops.
All right, everyone. Dr. Deuk will be joining us in the room shortly to answer your remaining questions, so go ahead and type them up in the chat now.
All right, Dr. Deuk Majin here. Thanks for joining us. This patient comes to us with herniated discs that are causing problems in the thoracic and lumbar spine. And she's already had a laminectomy that was done years ago. I did not do it. That was done at L5S1. And that surgery actually prevented me from being able to get into the L5S1 disc because there was so much what is called ectopic bone growth around the posterior elements, around the transverse processes and facets. Makes me wonder if that surgeon didn't try to do a fusion at the same time at L5S1. But we got into the L45 disc with a needle. I was able to test the L45 disc with a discogram called an evocative discogram, or known as a provocative. And that elicited her typical pain that she gets every day. It was a 10 out of 10 pain, and that pain was severe. It was in the typical location that she has pain. And so that tells us that the 045 disc herniation was indeed a cause of her symptoms, which is one of the reasons why we're fixing it for her back pain and her leg symptoms. Now, the more difficult disc to fix was the T11-12 herniation, which she's had for many, many years and has been causing bladder problems for her. So some of those bladder problems include difficulty holding her urine, frequency, and then of course you can get bladder infections. And so I was able to get in on the left side, which is the side the herniation was, and I used a smaller tube, a 4mm tube, that I typically use with cervical Deuk laser disc repair, endoscopic surgery, as well as thoracic. We were able to get in and get that fixed. There were a lot of pieces of herniation that we were able to remove. Of course, with all these endoscopic surgeries, we're not taking everything out. We're leaving most of the disc. We're leaving about 90 to 95% of the disc itself. That's why these patients don't need fusions and they don't need metal or artificial disc put in. When you have an endoscopic Deuk laser disc repair, we're actually just repairing a very small part of the disc in the back that's causing the problems with the pain in the neck back or pressure on the nerve roots or spinal cord. So we're actually only repairing 5% of the disc itself. We leave 95% of the disc there. That said, that's why we don't have to put metal in. So the companies that manufacture all the metal, they don't like this surgery because there's no need for metal and plastic to go into the patient. So they've been set against us for years, not wanting this technology out there. But it's better for patients because you don't need to have implants put in. Now, this patient also had facet pain on the right side at 045 L5S1. Facet pain is pain that comes from a joint in the spine called the facet joint. And I'll show you what that is. Where's my pointer, Sean? All right. Can you all see this joint right here? Right there. Yeah, they can see it. Now notice the facet joint is just behind the nerve root. That's the nerve root. And that's just, the nerve root is just behind the disc. And that's the herniated disc. So with the laser surgery, I went in and I repaired this disc herniation right here, the red thing. And I cleaned up the tear that it came out of so it doesn't come out anymore in the future once it's healed. And then Dr. Patel is treating the facet pain, the pain from this joint right here in the back of the spine, close to the disc. He's treating that pain by doing a rhizotomy. He's going to use a special probe that's going to heat up and kill a pain nerve to this joint. So this patient's getting really 2 procedures done at the lumbar region to get rid of her back pain, because she has pain not just from the herniated disc and annular tear, but also pain from the facet joints. So she should be wrapping up soon, and then hopefully we'll be able to interview her in a couple of hours when she's awake. In the meantime, we have a 3-level Deuk laser disc repair next, L344551. So 3 disc herniations. Actually, this patient has more than 3 disc herniations, but we're doing his surgery staged, meaning I can only do about 4 spots. So say if we did 4 herniations, I could do them all on the one side at a time. In his case, we're doing 3 at a time, and he'll be back again in a few weeks to do the opposite side. So this will be an interesting lumbar case. Any more questions, Sean?
Yes, we do have a few.
We do. All right. And I have coffee.
So one of our viewers is wondering, Doctor, I've had back pain for 4 years. My current doctors have done RFAs, medial branch blocks, and injections, but they don't help. They've told me a discectomy and a fusion won't help my pain. What is your opinion?
Well, great question. One of our viewers has had back pain for many years, and they've had the facet joints treated, which is really good. And then they've told this patient that having surgery will not help them. You are in a situation that so many people find themselves in. I'll tell you why. I will venture to guess that your rhizotomy procedures of your facets were done by a pain management doctor. Well, pain management doctors make money by keeping you in pain. They don't make money when you're out of pain. Think about it. You're not going to come see them, so they're not going to do procedures. So for pain management doctors, good ones, which there are not many, less than 5% of the ones out there are actually motivated and driven to eliminate your pain when possible. Remember, they can only treat certain causes of pain. And a lot of pain management doctors, interventional pain management doctors, they don't have the training to do all parts of the spine. So they may be good with the lower back, but they ignore the thoracic and cervical, because doing interventional pain management needle procedures in the neck and the thoracic are much riskier and require more training that most of these people don't get. So the interventionalists are very limited in what they can do for patients with chronic pain, and you're finding that out. Plus, unfortunately, many of them are not motivated to fix your pain. They want to keep you in pain, so you keep coming back, and you're like an annuity, where they just keep making money on you. That's not how we treat patients at Deuk Spine. It's a very different philosophy. We have enough patients. We have lots of patients. And We're not interested in keeping patients in treatment. We want to fix their pain so that they go and they live a normal life. And that is possible today, but it's not possible everywhere. It's only possible in a few places in the world. Deuk Spine Institute near Orlando, Florida is one of those places. So I can't tell you why you're having pain. It could be that your pain is coming from something that is 100% curable. In my opinion, that's what it is. But I don't know what structure is causing your pain because I don't trust your pain management doctor. I don't know their motivation. I don't know their competency level. So I have no idea what they've really done to you and whether they've done what's right for you. So that said, I treat every patient that comes to Deuk Spine like a clean slate. We're going to figure out where the pain's coming from first. I don't believe in having other doctors tell me where the pain's coming from. 99% of doctors that deal with back and neck pain, they have no clue where the pain's coming from. And they're wrong 99% of the time. So I have to make my own diagnoses as to the source of the pain. And I do that with a physical exam by examining the patient carefully and figuring out where their pain is coming from and where it's going to. That tells you a lot. And unfortunately, the physical exam these days, a lot of doctors just don't even do it. They think they can figure out where people's pain is coming from by looking at an MRI. You can't. I guarantee you can't. If you have a fracture or a tumor or an infection, okay, I can tell where your pain's coming from. I can see the infection on the MRI, and that's where your problem is. But people with chronic pain, long-standing pain from degenerative conditions of the spine, you can never tell based on an MRI, unless you're lucky and there's just one bad disc, and then you can tell. But I'm going to tell you right now, you need to go to an expert of degenerative spine conditions who will be able to figure out where the pain's coming from. So let's assume, to answer your question, that you are correct. It is a herniated disc, and that's the source of your pain. Can a fusion work? 100%. It will work if it's done properly at that level. Could the Deuk laser disc repair work that we just did? Absolutely. The Deuk laser disc repair is 1,000 times better than a fusion. You're not getting metal in your body. You're not losing the movement of the disc that fusion gives you. The Deuk laser disc repair is a natural debridement of the tear, removal of the herniation, and then your disc heals itself and you're pain-free. That's what I would recommend for anybody. I don't recommend fusion. I do fusions myself. I've done thousands and thousands of them in the last 25 years, and I do them very well. Would it work if it's done right? Yes, assuming your pain's coming from the disc. Now, just so you know, Deuk Spine Institute offers a free MRI review. And we look at your MRI and we do a video conference with you. So I can examine you over the camera and with sound, and I interact with you, and I can have somebody kind of point to your back to what different areas are, even press on different areas. So what I would recommend for you is to either come into the clinic and be evaluated by me and my team, or number two, set up a video conference after you mail us your MRI for a free MRI review. All of our video conferences and MRI reviews are free at this time. We do it as a basically just as to help people out. We do it complimentary for free. We don't charge, we don't make any money, we don't advertise. We just want people to get out of pain. We want to spread the message that back pain and neck pain is curable today, now, but you have to go to the right place. Deuk Spine Institute does it every day. Yeah. Next question.
Next question comes from a viewer on Facebook who's wondering, how do you know for sure that laser is better than fusion?
I know for sure. The laser's better than fusion. That's funny. Number one, I've done thousands of fusions myself, and nobody does a better fusion than I do. Nobody. My fusion patients literally go home in 2 or 3 hours. That's not done anywhere else. And I'm not talking about a one-level fusion. I'm talking about multi-level fusions. I do the most complicated, complex spinal fusions that you can do, and I do them outpatient. Patients go home in a few hours. We don't do them at the hospital. We do them in a surgery center. So fusion is a procedure where the patient's bones are getting fused together. So let's take a look at a fusion, okay? These are two vertebrae. Normally, these vertebrae move, okay? Normally, they move. So I don't have a model I could show you here, but normally, those bones move. As you bend and twist, the bones are moving. When you do a fusion, there's no more movement. You've lost that forever. It never comes back. those surgeons are fusing one bone to the other. So you have completely lost movement at that disc. Well, those are joints. Those discs are joints. They're meant to move. When you were created, you were meant to have 2 arms, 2 legs. If I start taking away things, like take away a leg, are you going to notice? Absolutely. So fusion does restrict movement, period. Now, the laser surgery I do does not restrict movement. There is no fusion of any bones. I'm actually going in and repairing the herniation. Okay, so natural movement's still there. Number 2, fusions are always done with very damaging big incisions, with muscle damage, bleeding, and pain, and bone is being chopped and cut. You cannot do a fusion without grinding the spinal bones, grinding them down. It's called fractures. We create fractures. The surgeon is going to fracture your vertebrae when they fuse you. That's 100%, no doubt about it. If the surgeon doesn't fracture your vertebrae, you will not fuse. So all spinal fusions require fracturing the end plates, fracturing the cortex of the bone. With my laser surgery, there is no fracturing at all. We don't fracture anything. As a matter of fact, with fusion surgery, the surgeon is going to pull bone out of your spine. And they may even take cadaver bone, bone from a dead person, and they're going to pack it in your body. If they don't take bone from a dead person, they're going to use your hip bone, which is even worse. They're going to be taking out parts of your hip bone and putting it in your spine. Don't let anyone do that to you. It's the worst thing that could happen. You will have pain from that area for the rest of your life. It's called iliac crest donor site, bone graft donor site pain. It's horrible. There's no cure. So fusions, just so far, number 1, you lose your movement. You're not supposed to lose movement. Number 2, you're fracturing the bones. Number 3, you're removing bone out of your spine. None of these things should ever happen. Number 4, you're going to be in so much pain with a fusion, you're going to end up being on narcotic painkillers. Those are those dangerous opioid medicines that everyone's talking about. You need those after a fusion. There's no fusion done where you don't take those, okay? With Deuk laser disc repair, we don't use any narcotics. We don't use any opioids. You take Tylenol and a muscle relaxer, maybe a little anti-inflammatory, but no opioids. Is that convincing enough yet? The next thing is fusions are almost always done in the hospital. Hospitals are dangerous places for spine surgery. You get an infection in the hospital. Once you're infected, you have all kinds of complications. Hospitals are also places where you end up getting blood clots, pneumonia, other dangerous conditions. With the laser surgery, we've had 0 complications, no pneumonia, no blood clots, no hospitalizations, nothing. 0. Over 1,300 surgeries, 16 years. So you get in the picture. Fusion, dangerous, painful. Deuk laser disc repair, safe, not painful. Fusion, you lose movement. Deuk laser disc repair, you preserve movement and actually improve movement. Fusion is overkill. A lot of collateral damage to the patient's spine and back. Laser surgery, there's no damage, no scar tissue. Fusion, massive scar tissue. Fusion done at the hospital. You don't want to be at the hospital for surgery. Laser surgery, Deuk laser disc repair is done outpatient. Basically, you're here for an hour or 2 and then you go home. Fusion, you're going to be down for months, not going to work, not doing your activities. Laser surgery, you go back to work, light duty, the next day. It's a no-brainer, folks. There's no doubt the Deuk laser disc repair is far better than a fusion. A fusion one day, it's going to be like fishing with dynamite versus fishing with a proper lure and catching the fish you want. It's barbaric, let's face it, okay? And by the way, I've done literally about 3,000 spinal fusions in my career of 25 years. That's a lot. Next question.
Next question comes from a viewer on YouTube is wondering, does a failed prior fusion where pain still persists after surgery make laser surgery more difficult to do in the same area?
Great question. So does a failed prior fusion make laser surgery more difficult to do in the same area? 100%, yeah. It's going to be more difficult for me because there's going to be a lot of scar tissue from the fusion surgery around the muscles. Oh, I forgot to mention one more thing. fusion surgery almost always kills the muscles of your spine, which you need, by the way, for posture and walking. And those muscles die. The fusion surgery takes the blood supply away, and those muscles literally die. With laser surgery, the muscles don't die, and your muscles are perfectly normal after the surgery. So another difference. Yeah, it does make it more difficult if you've had prior fusion. Doesn't mean we can't fix it with the laser surgery. I don't turn anyone away. There's probably a very, very few number of patients that I can't actually do the surgery, and because of anatomical constraints. But it's rare, but it is possible, and it's happened before.
And
Next question.
Our last question is, how do you manage such a quick 3-day turnaround time for patients visiting from out of town? Other surgeries need you in the hospital for more than a week.
A great question. So the question was, how do we at Deuk Spine Institute manage a 3-day turnaround for everything? That means the preoperative work that we do, seeing the patient, evaluating the patient in clinic, doing all the testing and imaging, and then the next day is surgery, and the next day they come in and get checked up, and then they go home. How do we manage 3 days? We strive for perfection. We strive to be the best. Look, the truth is that people want to recover quickly. There's no person on earth that has a spine problem that wants a prolonged treatment, that wants a prolonged recovery, that wants a prolonged anything, because spine conditions are painful, and the longer you're recovering from spine surgery, the more likely you're going to have complications. Okay, so let's think about it for a second. If you're in the hospital for a week with a spinal surgery, that's a week in a hospital where they treat people that come in every day with infection. That infected person could be put in the bed in your room, in the bed next to you, and it happens all the time at hospitals all over the world. And think about it. Now you've just gotten spine surgery. You're clean. You have no infected bacteria or viruses or anything, and you're on your way to a healthy recovery. And then they move somebody next to you that has pus coming out of their hip surgery they had done 2 weeks earlier. Well, the same people caring for that patient that has bacteria and pus coming out of their body are the ones caring for you. And they're literally going back and forth, and everyone's busy. And of course, you're supposed to wash hands and take precautions. And hospitals do that for the most part, but there are going to be lapses in cleanliness, let's just say. I mean, this happens all the time. That's one of the reasons I moved my surgeries out of the hospital. Let's say the guy next to you has diarrhea, all right? They have infectious diarrhea. What's the chance you're going to get it? High, at least 50%. It's communicable. It's an infection. It spreads. And, you know, maybe that you don't even see some of the infected material. It's microscopic, remember? So transmission of infections in a hospital environment is a serious and significant concern for anyone that's going to have back surgery. Why would you want to stay in the hospital for a week with sick people that have infections? You don't. And of course, there's COVID now, and that's spread all over through the hospital too, to the staff and the patients. So I love hospitals. I was born in a hospital. I've done most of my career in a hospital, but the Deuk Spine Institute has built the most state-of-the-art advanced spine surgery center in the world. We have the most advanced equipment. We have the most advanced medications. We have the most advanced protocols. We have the most advanced staff, and all they do is spine. And we are literally like, I don't even know how to tell you, we're literally the safest, most efficient, best spine center in the world. Why? Because we want to be. That's our goal. We want to be the very best. So recovery times, we want to make those short. The shorter the recovery time from spine surgery, the faster the patient gets back to a normal life. The faster you get back to walking, jogging, exercising, doing activities that are good for your body. The faster you're going to get off painkillers, right? Short recovery, short use of painkillers. Painkillers are not good. Even if it's Tylenol, muscle relaxers, or anti-inflammatories. Even if you stay away from the big narcotic opioid painkillers that have all kinds of complications, or benzodiazepines that are highly addicting. Even if you can avoid those, you still want to be on your medication for as short as time possible. Ideally, you never want to be on any medication. 50% of Deuk laser disc repair patients that we do here at Deuk Spine Institute, they don't take any pain medication at all, okay? You can't do that with a fusion. If you go to the hospital and have spine surgery, you're going to be on pain pills for weeks and weeks, even months, possibly years. So fast recovery is always better for patients. Getting your appetite back, getting your nutrition back quickly, getting your activity level back quickly, going back to work quickly, going back to your family life quickly. The shorter amount of time you're away from those normal activities, the better for the mind, the better for the physiology of your body, the safer for the body. So that's why our 3-day program, we've implemented it because it works. It's safe and it's best for the patient. It's that simple.
That was our last question.
All right. Join us in 20 minutes for the next surgery. Go get some popcorn and a Diet